Thank you very much for everyone joining. My name is Kwabna Ansar. I'm the Head of Communities here at the LOPE Agency. We're very happy to have everybody here attending with me today. I've got my colleague Amina.
Hello, I'm Amina. I'm a multicultural specialist at LOPE Agency.
And we have Dr. Holly Siegel here today. So just a bit of, before we kick off, just wanted to obviously introduce who LOPE is as a business. So we're a unique multicultural marketing agency that specialises in ensuring effective communication with our audience from a diverse group of cultures. We do everything from marketing right through to strategic designs and placements for some of Australia's largest organisations. So it's a pleasure to have you all here today. Just in terms of the structure of today's webinar, what we'll have before we kick off, a little poll. So I kind of wanted to just get an idea as to what everyone's idea of engagement is with CALD community. So you'll be able to do that through Zoom, and we'll be able to see the results. We'll share those results later throughout at the end of Dr. Seale's presentation, and we'll be able to then go into Q&A. So we'll have a Q&A section. So throughout the course of this presentation, you can, in the Zoom function down, I know everyone's used Zoom for the last year and a bit, you can ask questions through that chat function down there. Also as well, whilst we're in that Q&A section, please feel free to raise your hand and provide us with a question. We'll do our best. Thank you to everyone who has provided their questions during the registration process, and we've got that on hand. So we'll be kicking off the Q&A with that. In terms of the structure of it, that's basically it. We're very much looking forward to Dr. Seale sharing her knowledge with us all. So before we start, I'll just shoot up this poll for everyone to have a go. So please engage in the poll, and we'll be able to give everyone gather all the responses and share with you later. We'll give them some background music while they do their poll. We're nearly there. Just got a few more people left. Okay. Fantastic. All right, I'll hand over to my colleague Amina to introduce Dr. Holly Siegel.
So I'd like to introduce our special guest speaker, the Associate Professor, Dr. Holly Siegel. Holly is an infectious disease social scientist at the School of Population Health at the University of New South Wales. She also is a deputy chair for the Collaboration in Social Science and Immunization. She's got over 50 years of experience and impressive 150 publications focused on engagement of different at-risk groups with immunization and other prevention strategies. Her research focuses on promoting acceptance and uptake of immunization focused on groups that traditionally have received less attention and continue to have suboptimal uptake, such as children or adults with chronic medical conditions, culturally, linguistically diverse communities, migrants and refugees, and occupational groups, including hospital healthcare providers. During the COVID-19 pandemic, she's worked on strategies that will enhance communication and engagement with people from diverse backgrounds, particularly regarding COVID-19 vaccine. She has been consulting with the World Health Organization to develop guidance documents to support vaccination efforts. So this is absolutely impressive, and we are happy to have such a great expert like you, Holly, today. So we've got a lot to discuss today, and without further ado, let's get started.
Thanks, Amina, and that's very kind of you. And hello, everybody, and thank you for the opportunity to present. While I just get my slide set going, just give me a second, bear with me. Does that look correct? Amina, does that look right? Excellent. So hello, everybody, and again, thank you for this great opportunity to present. Just to note, the work that I'm presenting today is independent and was researcher driven. It wasn't funded in any way by the agency or by the government. It really was just, our initiative in terms of seeing a gap and feeling that there was a need to do this research. There we go. Before I begin, I'd like to acknowledge the traditional owners of the land that I'm presenting from today. So I'm sitting here at the University of New South Wales, so I pay respects to the Gadigal and Bidjigal people who traditionally occupied the Sydney coastlines, and pay my respects to any elders past, present or emerging, and any Aboriginal and Torres Strait Islander people who are joining this call today. What I want to do over the next 20 minutes is take a little bit of a journey back, firstly, in terms of looking at vaccine acceptance, and then kind of going deep into the research and the issues that we identified, and starting to think through about some solutions that we could be adopting, adapting, and utilising in our communities. I've had a long interest in enhancing immunisation programs within migrant and refugee populations, and have been working in this space for about 15 years, looking at how do we promote vaccination in general to children and adults, and also traveller-related vaccination, which we know is important when people are visiting friends and relatives. The challenge is with all of those programs is that we are starting at a place that we don't have equity between our immigrant populations and our Australian-born populations. From the slide here, you can see that I've presented some data looking at influenza vaccine uptake amongst Australian adults. And there is a significant difference between acceptance and uptake amongst those who are Australian-born to those who have migrated into Australia. I could have presented also data that is relevant to our childhood programs, immunisation programs, but the same thing is true. There is a distinct gap between coverage in Australian-born children and those who are from immigrant parents. Why I chose the adult space is because we know that for the COVID vaccine at the moment, we are focused on uptake amongst adults. In this setting, and whenever I talk to migrant and refugee populations, the first message that I hear is that they believe in vaccination and accept vaccination. And so that is important when we think now about some of the challenges impacting on vaccine uptake and why we don't have equity in our coverage. It's not maybe because of what they think and feel about the vaccines or the diseases themselves. but because of other factors that need to be considered. And I've put some of these here. So what we know before COVID, looking just generally at immunization, that there that issues such as literacy, being able to understand the recommendations around vaccination or the eligibility information, being able to actually navigate the systems to access a vaccine, and other issues like financial constraints all play a role in contributing to that difference between uptake in population groups. Looking forward now and looking at willingness to accept the COVID vaccine, we are seeing some clear pictures come through in terms of the the elements or the social drivers which will influence people's behaviors around this new vaccine. And, some of these elements are not too surprising. Things like risk perception, feeling worried, maybe misunderstandings about eligibility are common elements that we see across any vaccine program. But what we're hearing a lot here at the moment is concerns also around safety and that needing to be reassured around how these vaccines were developed and about the safety profile for them. The challenge with these studies is that a lot of these have been done, and my study included, in more convenient-based populations, in ways that can be done rapidly and repeatedly, but that may not always work to capturing the attitudes and behaviors of all of the populations within our communities. And so that's really important when we look at these studies. Do we actually feel that they are, the findings are translatable across all populations? So when we look at vaccine acceptance for this COVID vaccine, a lot of people are talking about, well, we've got to address complacency, we've got to address confidence, and to one degree also convenience. And these then fit into the 3C model that has been used traditionally to support improvements in how we roll out and run our vaccine programs. But I'm going to suggest, and I'm going to skip over those little antidotes, that instead we should be thinking about this model and considering this when we are now putting together our communication, but also thinking about how to support our communities to get to receiving a vaccine. And this model puts equal weighting on those attitudinal and behavioral factors, but also about the elements that promote uptake. And they are the access factors, they're the affordability factors. It's about looking at the whole program holistically and making sure that we have the correct touch points there to enhance uptake. So I'm going to try and talk to these elements while I go through the presentation. Just as a little bit of a background, how we came about and all of the data we collected really comes from talking to people who are on the ground working within the multicultural sector. So we did in-depth interviews with stakeholders from government, non-government, community groups, settlement organisations, private translator services, refugee health services, a huge range of different organisations spread across Australia, except for the Northern Territory, and we're still having some ongoing recruitment to make sure we do capture every state and territory to really understand, well, what happened last year, what's been happening in terms of, the strategies used to just communicate in general during the pandemic, what strategies were used to keep in contact and to touch base with the community members, and also then what lessons can be learned to actually then enhance the communication and actual rollout of the vaccine program. So there are others doing great work in this space. And what we're trying to do really is to look at the vaccine program, but using a lens of what was done last year to help with that. The model and this little bit of a figure down here, again, talks to what I was just talking about in terms of the 5 A's. It's a model that's been put out by the WHO, and it really, again, highlights that when we're thinking about how do we support vaccine development and, vaccine implementation, is that we are thinking about it along the spectrum. So it's from what people think and feel, making sure that we address their confidence and their understanding. How do we address kind of community mobilization and getting everybody to come together if that's appropriate, all the way through to those practical issues of how do we get people to engage with the booking system and actually turn up to a clinic when they have their appointment. And these are the results that we have got. I'm not going to touch on all of them. I'm conscious of time and I want to make sure we have plenty of Q&A opportunities. Don't mind me, I've got this little fly buzzing in front of my face. We have got, so I'm going to go through 3 kind of key results. First is really about kind of what we identified, and I think what is probably well known amongst people on this call about the information gaps. And if I heard the word void, I heard it once, I heard it across every interview. And that was really that sense of what happened last year, that there were time points, during the pandemic where information was just, not coming through. Either it was not available, it was not in the correct translated languages that were needed, or that the translations were not appropriate, in whether that be because of the literacy level or because of issues with translation. And so to fill that void, a lot of the people we spoke to highlighted that, information is just coming in from overseas. People are watching and streaming their news from their country of origin, or filling that void also with information on social media and also via kind of the short messaging services like WhatsApp and WeChat to touch base. And the problem there is the conflict between what they were hearing happening and overseas and the recommendations and the practices overseas compared to what was being suggested here in Australia. Mainstream media was really kind of, suggested as just not fitting the mold right now. Even, people spoke about the fact that SBS just really wasn't the service that is needed, and that not enough emphasis was placed on using ethnic newspapers and radio to really get in and disseminate messaging into the communities. But what we know, and from all of these community groups that I was speaking to, that they were doing a huge amount, and I can't, express that enough, to try and ensure that their community members remained engaged. And so, these organizations were telling me that they were making thousands of phone calls every week to do well-being checks with their clients or with their community members. They were door knocking, they were doing Zoom chats, they were doing face-to-face meetings when appropriate and allowable. They were even doing kind of, what maybe some consider just old school, bringing people together via telephone chats on a Saturday night to allow people to ask questions or to express about any issues. And so, there was a lot of engagement happening last year. What we know from all of these organizations is that they were doing a lot of they were receiving the government information, whether it was coming from local, state or federal levels. They were tailoring the information. They were translating the information, they were adapting and adopting the information, and then they were sending it back out there. And so there was some concerns and some hesitation raised about whether or not messages were going back out in a consistent way, whether messages were capturing the most accurate information, and also whether that kind of, the language that was being used was the best to try and motivate people to adopt the public health behaviours. Our stakeholders that we interviewed spoke a lot about community leaders and about the key role that community leaders play in being that touch point between government, non-government, and the community organisation and back into the community. But having said that, there was some concerns raised in this space, and these were from the fact that there was concerns around community leaders burning out, being asked again and again and again to be that touch point in a space where no resources were given or no funding was given. And this isn't an issue about their willingness. Nobody said that these community leaders were not willing, but being conscious that all the time, and this is especially critical going forward, that being asked to talk about these public health messages comes with an emotional burden, that you as a community leader must understand them, must feel comfortable and confident in communicating about them, and then feel that you have then the energy to go out and to do that again and again. And so people were very conscious about this. And this isn't a new issue. This has been an issue ongoing, but an issue that maybe really, now's the time to kind of find some strategies around. There was also, discussion around the fact that maybe not every community has, such a strong group of leaders available, or that some leaders may actually be gatekeepers and may not necessarily have the reach and dissemination into the community that perhaps we are assuming that could happen. There was also concerns raised about how we are actually working with community leaders, that it's not enough to just develop a script and to put a community leader in front of a camera, that doesn't equal community engagement, that engagement actually is about working with the community leaders to develop the messages from scratch. There was also concerns about the fact that we may be doing really well in urban settings and our big cities and our big hubs, but what happens when we look out to rural and remote areas, and whether or not we're still having that same sort of influence by working with community leaders across all areas of Australia. One suggestion was to kind of have a think about who are we actually talking about when we talk about community leaders, and whether or not we can expand that to include other kind of natural leaders. So people who may, for example, have had a health background in their country of origin and may not have been registered to work here in Australia, but people who may have the confidence to still talk about health and health issues, and interpret all the jargon and terminology, and actually work then back into community. But also a lot of emphasis was spoken about the need to get bilingual staff across all sectors, and also work with other community ambassadors, whether they be our caseworkers, settlement workers, and others that work out of community organisations. Lastly, really, and the key thing here is talking about these access issues and delivery factors that need to be part of our dialogue as much as thinking about communication at the front end. And this is really, to think about, well, across the process of actually trying to get a vaccine into someone's arm, what can we do to make that process as easy as possible? To break down any issues around navigation of health systems or concerns around literacy levels when actually trying to book into the system. And so really a lot of people spoke about the booking system, or kind of what they envisaged was the booking system, and whether or not that would have opportunities for, differently, whether it will be available in other languages, whether phone booking systems will be in play, whether translators are around, those kind of concerns around making it as flexible as possible. A lot of issues were raised also about the delivery of the clinics themselves, and whether or not there is sufficient flexibility in where the clinics are being held, whether or not they really represent the most centralized and appropriate locations for the communities we're trying to support to get vaccinated, and also whether or not we've got the right mix of people at those clinics, including translators, bilingual staff, and bilingual medical staff as well. There was also issues around the fact that we are going to be entering a space where there's going to be a lot of conflicting information coming through, especially because here in Australia, we do have the two particular vaccines being delivered, which may be different to what vaccines are being used in country of origin, and that kind of little bit of a conflict in terms of hearing about the eligibility, who's actually should be targeted for vaccination, what products are being used, and I suppose right now the fact that we have got some programs being suspended or delayed at the moment because of the issues about capturing more information about the vaccines. So there is a lot to unpack right now, and this is the challenge, that when you have a community where information does take time to disseminate, whether or not we're getting those messages through quickly enough. I've just gone through quite quickly a lot of the results from our study, but what I ask you to do, if you want any of those further details about what we found, to please have a look at the flyer that's now publicly available about those results. And the flyer also includes what we propose as some solutions going forward. And what I've tried to do is put these solutions out to those kind of key kind of elements that the WHO recommends we focus on, which also talks to that 5 A's model. So front end, focusing on communication. How do we make sure that it's not just about the development of the messages, but the dissemination of the messages, and making sure that we really utilize all of those great resources that I've been hearing about in these community groups, in terms of the magazines they put out, the newspapers that are put out, the community radio opportunities, but also the fact that people, these community organizations, have the touch points in via the closed systems of WhatsApp and WeChat, and also the social media. That any audio-visual materials need to be developed with community, and they need to be continually developed and tweaked. That messages might change, messages might need to be adapted based on what happens, and that we need to be a little bit more proactive in being ready. So, if there is a safety episode that does, if a safety episode occurs, we don't want things to fall down. We want to have some resilience in our system, so that if we do need to pivot quickly and get some safety messages out, that we have those to hand, or we've gone through the process of who's going to do those safety messages quickly. Really, what we've been hearing is that community groups, community members want the opportunity for forums. They want the opportunity to talk to local GPs in language, talk to local nurses, bilingual staff, and also to the government's representatives about the program, and get any questions addressed here. The last thing, which I think we all agree on, is that we need ongoing data collection here, and whether or not that be talking to those who are kind of behind the scenes in terms of supporting community, delivering programs and so forth, and or the community members themselves. It needs to be continual. We need to have those touch points happening. Beyond that, and ensuring that we get people to turn up to vaccine clinics, we need to do some work to activate them, to motivate them. And this is where really then we will be coming back in and needing to work with our community ambassadors or champions. And what I propose here is, and what has been echoed by those that I've been talking to, is that we need to start paying some people here. It can't just be on goodwill. It's not enough anymore. When we do in Australia census collections every X amount of years, we employ people to actually be bilingual engagement officers for that process, to go back into community, to be a community face, talking to community members about the need for census and to participate in census. You know, there's no difference here. This is what we need. We need people on the ground at community forums, at community events, at faith-based organizations, you know, even turning up to things like, you know, seniors groups or, you know, mothers groups, you know, those opportunities where people come together. We must do a lot more about, you know, actually having some touch points and some agreed, you know, kind of best practice recommendations around how we're going to use closed systems such as the WhatsApps to disseminate messages, because I think we're working in a little bit of an unknown space there. And lastly, in this space, we need to do some work around supporting our community ambassadors to develop their and hone their skills around communicating around vaccination. You know, we know that these people are very strong communicators in their community. Talking about immunization can have its caveats, and we even know from the research done with GPs and other immunization providers that it can be challenging sometimes to talk to people about immunization. It can be an emotional space. It can get people to be aggressive if the conversation, you know, is not framed correctly, and that's what we want to avoid. We don't want to get people to a point where they are turning around and being vocal vaccine deniers, because we don't want those, you know, that kind of confrontational space. We want to enter conversations in a way that supports best practice in terms of that two-way conversations, and to ensure that doors stay open and that community members then go on to talk to health providers who can maybe address more those kind of nuanced safety factors. And so I've really been hearing about some great stuff happening in this space. But what I would suggest is, you know, right now it seems to be a little bit piecemeal and a little bit state by state, that this training needs to go national, that it's not enough to just hold forums to talk about the logistics of these vaccines. We also need some forums and some training opportunities to talk about vaccine communication and about how to address misinformation if it comes into either a virtual space or a face-to-face space. Beyond that and the practical issues, I think I have spoken a lot to all of those elements, so I will, in the conscious of time, keep going. And really to say a big thank you to the participants and stakeholders that spoke to me during these interviews. The study is ongoing, and if you feel you would be interested in participating, you know, I would love to hear from you. We are also now in the process of recruiting community leaders to interview them about their experiences and about what would best support them going forward. That particular piece of work is currently only happening in New South Wales. And so if you are a community leader or a community group in New South Wales, again, please reach out. We would love to work with you to try and ensure that we are hearing the voices of our community leaders as well. So this is my research colleagues that have been part of this journey. A huge shout out to them, especially Lisa Woodland at the New South Wales Multicultural Health Communication Service. She has been instrumental in getting this work and opening doors for me. And you know, really to the rest of the team, you know, it's been a great journey, and I've learned so much that I think will not only support COVID vaccine acceptance and uptake, but hopefully going down the track, really start to break down those equity issues that we have with our other vaccine programs. So thank you, and look forward to question time. I'm going to stop sharing.
Well, Dr. Seale, that was amazing. I learned a lot from that presentation, and I hope everyone watching in on this webinar learned a lot from what she had to say. Now, just real quickly, I'm just going to share the results of the poll, just so everyone can see what we thought at the beginning. And so here it is. So as we can see, is the COVID-19 vaccination message reaching the CALD community? Majority of people said maybe, and that's a real indication that there's a lot more work to be done. And also what types of communication channels work best for CALD communities. And we've got in-language radio, followed in by religious organisations. And so that's a real avenue that I think Dr. Holly Siegel mentioned.
Being cheeky, I'm going to take a photo of that. That's great. Lovely to hear it. And it supports what we're saying. Thank you, everyone.
Indeed. So what communication barriers are facing CALD community members from being vaccinated? A clear winner with a second in behind. Not all community members are part of the virtual community, and variation in health literacy levels amongst communities. So it seemed like everyone was quite important. And should there be more funding? A resounding yes for CALD communication. So certainly, and with that, some of the questions that we received from participants, Doctor, talked about the Ottawa Charter for Health Promotions, which you touched on. You touched on the WHO and the work that they're doing. So the real question here is, how can community advocates and leaders be brought into the communication tent of large organisations while also creating safe spaces for communities to talk without being shut down by naysayers, one would say?
Yeah, look, that is a good point. And, this is where I suppose we need to be conscious about, what do we know about the community that we're focusing on and their current willingness levels. We could make some assumptions and think that, based on what we know so far, that around 80% of, or maybe about 70 to 80% of our population have indicated at some point that they would be willing to get vaccinated. And so, we may be entering into a space where people, they are curious, they are wanting further clarification, and they may also just want to hear some personal stories around all this. So this is, I suppose, where community leaders, really come in. They need to be there at the front end. They need to be there as part of the development of materials, of the kind of the tailoring of the messages that are going to go out. But what I think is going to be a key element is them telling about their reason for getting vaccinated. Now, this is, I suppose, a little bit where further clarification needs to be had, because I know that there are some information about what companies and organizations can say about immunization and about the COVID vaccination. So we would have a little bit of that came out in the media around, not naming the particular vaccines, not using brands. And there are some other, rules about what medical professionals can say. But when it actually comes to a community group, I think we need to question about where do those where do those rules start and stop, and and I think some common sense is needed here. When you are sharing stories within community, we know that storytelling has had a huge place in other public health programs back in country and here in Australia. And so, and I was talking to another group about this the other day, that, if I share a story about my personal reasons for vaccination, I'm not necessarily pushing an agenda onto someone, but instead I'm highlighting the element that motivated me. So if a community leader does have a presence and is what we call, would define as a kind of a diffuser in their community. So someone who, brings people along, someone who is looked up to in terms of their opinion, by them actually, coming out and stating, whether it be on social media or on the radio, I received this COVID vaccine because I have an elderly parent who I need to care for and I want to protect. Or, I'm getting this COVID vaccine because, I'm hoping that this program helps to ensure down the track that we can open borders again and travel back overseas to see family members. I haven't seen family members for 9 months. I'd love to go and see them. And that's a really powerful story that, I think we need to be getting out there more. I am seeing it in the healthcare sector that, when people in hospitals, the healthcare workers, often we are seeing them getting photographed, rolling up their sleeves and getting the vaccine, or, having a kind of a little motto to go with their vaccine. And, again, this is the kind of things that we can do, this kind of social marketing somewhat, strategies amongst our own communities. It may be just as powerful to tell that story around a kitchen table, a dining table with friends and relatives, as much as it is to share publicly. So that's what we need to be conscious of.
No, excellent. That's good. Amina?
Thank you, Holly. We've got a second question. How do you cater for all health literacy levels with just one document? We find our refugee communities at the level vary hugely.
Yep, and that is a challenge at the moment, that we have been somewhat reliant on having that kind of one piece of paper to cater for all groups. And what we need to do then, and this is, I suppose, that balance out, that we don't want to overload the system with resources if they're not going to be used, but instead, assume that yes, that resource may be useful for some members of the community, but then how do we get it out otherwise? And what I've been hearing, a lot of it needs to be going out verbally, a lot of it needs to be going out via videos, and so that within those other contexts, we need to then be careful and conscious of how we talk about these vaccines verbally and via video. And health literacy is it's a common denominator across all of Australia. We know, looking at any population within Australia, that about 60% of Australians have inadequate health literacy. So health literacy also is a bit of a jargony term. And for those, really what we're trying to say is the ability to interpret and use health information to go forth and do the health practice promoted. And so what I suppose from our health department staff all the way down to our community groups is just being conscious of the information we put on our slides, the information we put out in our posts, and what we're saying verbally, because immunization comes with a whole bucket of jargon, and these vaccines themselves also have a huge amount of jargon that, I've spent time now having to go through. So I feel a little bit more confident in some of these terms, and let's acknowledge that, because things like mRNA vaccination, I haven't normally spoken about that because, these are vaccines that are being used in different contexts overseas, but not necessarily here in Australia to date. And so I've spent some time, trying to make sure I understand that term and what it means, so that I can try and speak about it in a way that helps. And so, really then, and we definitely all need to spend a bit of time thinking about this. I've been to, I was attending a workshop done by one of the health departments, I won't name who, where, within the space of an hour, I think I lost track of how many different terms were used, A for the word vaccine, vaccination, immunization, jab, shot, the list goes on. Even someone said to me, well, what does rollout mean? So we make some assumptions around, these words we're saying every day without being conscious of, well, what does it mean to community? So we need to all play an active role in trying to stop that bad habit.
Fantastic. I mean, we've had, there's been a question in the Q&A function talking about emergency services and the information and having different lens around there. We also got a question from one of the participants around emergency services. So putting on your hat and taking you away from the health side of things, Dr. Seale, what strategies would you suggest for communication, not just in health, but within other organisations to CALD communities?
Yeah, look, and I'm you can see my eyes darting because I've been trying to just read that emergency response space, and I think that is important because the work we've been doing around pandemic, it's relevant to other emerging situations, and and whether they be of an infectious disease type, but also you mentioned about bushfires or floods. And, this is something where, we make assumptions that, if we turn on our 7 o'clock or 6 o'clock news, that we'll get that update about the situation, or that we know what particular apps to use to look for information. But that is not consistent in all populations. And I think the key thing here is, for some of this to be pushed back onto governments, who, yes, do a really good job, but also need to have a think about it from a consumer point of view about how do websites operate? How do we actually navigate information on different sites around any of these kind of emergencies? And I think this is true for bushfires. We had that horrific situation, at the beginning of in late 2019, early 2020, and this was, I don't know, whether there is any evidence to say how did bushfire communication happen and how effective it was during those scenarios, and I think that is something that needs to be looked into more. But I think definitely, and just pulling back on my data, which is where I've always kind of got to ground myself, is that a lot of people have said that the government website is just, you don't know where to start some days, and it's about thinking about how to navigate it, thinking about, of course, what we just spoke about with the health literacy, but also making sure that the materials being included actually resonate with the community members that they are trying to be targeted at. And we spend a lot of time trying to talk about text, but some of the visual elements can be just as important too. And I've already raised this with, some of the materials coming through with from international agencies and domestic agencies in terms of the vaccine promotion, is that, we often get a picture of someone with a big needle going into somebody's arm. So if I can give you any kind of suggestion, let's get rid of the needle photo. It drives me insane. There is no need to show it. From a kind of a social science perspective around immunization, what we've been trying to promote is just to show the Band-Aid on someone's arm. It's much, much easier, especially if you've got a community members who are needle phobic, which can happen in adult situations. But what it is also is in making sure that our visual material talks to the diversity of our communities and talks to diversity in organizations, such as even within health organizations, that we have, we represented by category of staff, by gender, but also by diversity. And we don't spend enough time talking about that. How do you get them starting to talk in simpler language? I'm just seeing that question through from Rima about this particular point. Rima, we published a paper about this last year. So I'm going to give a shout out to my colleague Ikram Abdi, who published a paper on the health literacy levels of immunisation information focused for migrants and refugees. And we found it was off the scale in terms of the challenge, how difficult it was, and just finding it in itself. Rima, I'd be happy to post that paper out if you've got an interest. And this is something that really we need to spend more time on, with immunisation generally here. Should we go back to the other questions? I've got on a bit of a tangent then.
No, absolutely fine. Look, we've had Rodney as well kind of make a bit of a statement about the TGA, and what are your thoughts on that in terms of the guidelines around there? And he discussed about, making in language videos for specific communities, and what are your thoughts? I mean, making in language videos or providing documentation and resources specific to communities, is that helping community?
We have to do it. This would be madness if we weren't. And so, I think this is where we do need some further dialogue. And I have to admit that even I still need someone to work through those guidelines with me, and to get that clarity around what is allowable or not. And I suppose what needs to be defined firstly is who is the target audience for those TGA guidelines. And so are they focused for people who are maybe in medical, pharmacy, people who would be delivering the vaccine, whether they are a private group who have been given, the contract to deliver vaccination. Are they, is it government organisations? Who is bound by those regulations? And also then, if it is for everybody, then what is that allowance, and where do we draw the line? Because we've got to come back to the literature. We've got to come back with what we know supports vaccine acceptance and confidence, and motivation. And what we know is all of that has got to be tailored to the group you're trying to talk to. It's got to be in language, and it's got to be disseminated by the voices that mean something in community in a way that is meaningful to community.
Fantastic. So I guess, sorry, Amina.
Yeah, I was about to catch up and say, I guess it's the time to wrap up our webinar. It was a great presentation, and we hope everyone got some very useful and important insights. And we received quite good feedback from some of the guests, so thank you all for that. And yeah, we will be happy to share the materials in the presentation and the flyer. We'll be happy to distribute that through the email, or we'll find the ways.
And Amina, I suppose if anyone still had questions or anything they'd like to bring up, more than welcome to drop me an email directly, and I can keep the conversation going. But also maybe we could be pushing up the line about this question about the advertising guidelines, because I think that needs some action.
No problems. Well, thank you so much, Dr. Seale. Everyone here, we will be sending out an email to everyone, and including Dr. Seale's contact details, so that you can get in touch. Again, thank you again for participating. This is LOT's webinar series, and we'll continue to be doing webinar series throughout the year. We have some interesting topics coming ahead. So thank you so much, and stay safe.
I'm looking forward to see you again.
See you later.